Okay. So hi everyone. My name is Olivia Gergley, um, and I'm doing a presentation on improving mental health outcomes during pregnancy, labor, and postpartum for survivors of sexual violence. I'm a student at the University of Regina. I'm in health studies, and I'm doing my fieldwork here at the Regina Sexual Assault Center. Um, and yeah, so this is a topic that's not frequently spoken about, and there's not a lot of research and literature to the specific experiences of survivors during the perinatal period. So I hope that my research aims to fill some of the gaps and bring more awareness to the subject of supporting survivors during their perinatal care. So this content will be recorded, but for the privacy of others, only I in the presentation will be recorded. And there is question and answers at the end. So feel free to leave them in the chat, but I won't be going to answer them until the end of the presentation. So just as a land acknowledgement before we start, that the Regina Sexual Assault Center is situated on Treaty 4 land and the homeland of the Métis. Our organization recognizes that colonialization and systemic racism have contributed to sexual violence experienced by Indigenous peoples and are committed to our role in the truth and reconciliation process. And just as a trigger warning, we are going to be talking about sexual violence. So if any topic is too sensitive for you, feel free to mute me, and remember to take care of yourself after this presentation. So just as a topic outline, I have these little symbols that you'll see in the corners of each slide, just so you know where we're kind of at. So the first topic we're going to be talking about is some background about sexual violence and its impact on survivors. The second topic is pregnancy, labor, and postpartum outcomes of sexual violence survivors. So these are kind of situations that contribute to the re-traumatization that could adversely impact their mental health. The third is trauma-informed care. So kind of what is it? And the fourth is trauma-informed care in practice. So improving the perinatal mental health and implementing sensitive care. So first, I'll start off by defining what is sexual violence. So sexual violence is kind of an umbrella term for any form of unwanted sexual contact. So this can include an assault, abuse, which is more ongoing, or harassment, which is more indirect sexual contact. So sexual violence can impact anyone. However, there are more groups at an increased risk, including women, children, Black, Indigenous, and people of color, those who identify as Two-Spirit LGBTQ, individuals experiencing homelessness, and individuals with a disability. So I put a couple stats on the side of who is more likely to experience sexual assault, and Indigenous women are 3 times more likely, 2S LGBTQ are 6 times more likely, and those with a disability are 2 times more likely. So if we consider the concept of intersectionality, where we take into account the overlap of multiple social factors, such as gender, socioeconomic status, race, sexual orientation, or physical ability, the risk can be even higher. So this could be an Indigenous woman with a disability or a bisexual woman who is experiencing homelessness. And this is because the root of sexual victimization against minority groups is oppression and inequality. Unfortunately, they are a target because of the lesser perceived power that can result in these groups lacking access to resources, and it makes it more challenging to report. So perpetrators view the victim as unequal, and it fuels that rationale of control and abuse. So the effects of sexual violence can have immediate and long-term impacts. And if not treated, it can develop into a mental disorder such as anxiety, depression, eating disorder, sleep disorders, or post-traumatic stress disorder. And PTSD is especially important as the responses experienced are due to re-traumatization and stress. So some survivors can experience shame, so feeling like they're bad or wrong or flawed in any way. They can feel guilt, so thinking that the abuse was their fault. They can also experience fear, continuing anxiety, disassociation, so kind of that out of body experience, flashbacks, and difficulty trusting in their self and others. And the association between sexual abuse and mental health symptoms can affect anyone, but the physical responses and psychological experiences can vary between people. So during pregnancy, labor, and postpartum, individuals have an increased risk of developing or resurfacing of mental disorders. So for example, it could be from a pre-existing mental illness. So say you struggled with some depression in your teenage years, but once you got pregnant, that resurfaced and came back full force. It could also be from the changes in hormones, lifestyle changes, fatigue, stress, difficult or traumatic birth, societal pressures, and prior trauma. And prior trauma is an important topic because that's kind of what we're talking about today. So the most common disorders experienced by survivors are anxiety, depression, and PTSD. However, PTSD is a primary concern, as many survivors experience it, especially those exposed to childhood sexual abuse. The risk is 5 times higher compared to those with no history of abuse. So those who are pregnant with PTSD are at an increased risk of adverse outcomes in themselves and their children, such as prematurity, low birth weight, postpartum depression, impaired bonding, and being less likely to breastfeed. And I also wanted to throw in these stats for the most common traumas in birthing women, which are sexual violence and intimate partner violence. And it's important to consider these stats because this is a lot of people suffering from trauma that gets resurfaced during their pregnancy. And these numbers could be even higher, as 91% of assaults go unreported. So we're on to our second topic of perinatal outcomes of sexual violence survivors. So within prenatal care, childbirth, and postpartum care, the procedures and practices can re-traumatize survivors because it focuses on areas of the body associated with sexual violence. And even though survivors may desire to be pregnant, conceiving and carrying out a pregnancy can be associated with trauma and negative feelings and sensations. So in clinical procedures and care, survivors can experience, again, shame, guilt, and even humiliation, fear, hopelessness, and anger, and loss of control. And loss of control is really important because that's one topic that I saw broadly throughout all the research that I've done. So therefore, their main concerns are the need for control, as well as disclosure challenges, disassociation, recoping or coping during re-experiencing, so flashbacks, and vulnerability. So these next few slides I'm going to go through are kind of situations that arise in each perinatal stage that can bring up feelings of re-traumatization and these adverse experiences. So in the pregnancy stage, exams are frequent and have a lot of physical contact and can be quite invasive. For example, a pelvic exam, they're asked to lie down, undress, and open their legs, which can be a flashback. Also, the power dynamic of the healthcare professional can be reminiscent of the perpetrator. So these two factors can cause the survivor to avoid or prolong the attendance of exams, which can increase the risk of prenatal complications. And kind of to deal with the trauma and stress that they're feeling, there is an increased risk of alcohol and substance use. So that can also lead to more complications. And also fetal movements in utero. So in a qualitative study that I examined that looked through the pregnancy experiences of childhood sexual assault survivors, loss of control in fetal movements was a big theme because it can feel the same as when they were abused. So I took a quote from the research, and they stated, "I felt very much trapped. This feeling of being controlled and being manipulated by other people and not feeling like I could do what I wanted to do." So in the labor stage, childbirth in and of itself can be traumatic, as 1 in 3 people who give birth experience birth trauma. However, those with a history of abuse are 12 times more likely to experience birth as traumatic. And this is because loss of control is the leading trauma response. And when you're giving birth, there's just a lack of it. And this fear is especially true for childhood sexual abuse survivors, as the body remembers feeling powerless in past situations and attributes a pattern to future encounters like childbirth. So the loss of control can be from labor pains or epidurals. And although many request an epidural, being confined and temporarily losing sensations can trigger physical and emotional paralysis that was once felt and sexual abuse. It can also be from the male physicians or having many unknown people in the room. So maybe some students are watching your birth. It can also be from physical touch. So maybe like the rubbing of shoulders or any other body part, or it could be from the language used. So phrases like sweetie, relax, it'll be over soon. Just things like that can really re-traumatize the survivor. And the providers believe that it's helpful when it could not be. And also the birthing position. So having your legs up and being exposed to everyone in the room and not having a lot of coverage, or even having their back to the door and not being able to know who's entering the room. So in the postpartum stage, breastfeeding is a common trigger of re-traumatization for survivors. This could be due to pressures from the physician or provider, or even from your peers. And for some survivors, they can be empowered by breastfeeding, but others may feel animosity towards it, and it can reawaken flashbacks of abuse. And this can result in fear, anxiety, and disgust towards yourself and the baby. And from the same study I had referenced before, one participant stated, "It's like it's happening again because you're being controlled by another person." And even though I really tried to not feel like that, it happened every single time that I tried breastfeeding. I felt that immense feeling of being controlled by someone else. And survivors can also experience overprotection. So in another study that I looked at, the main theme for the perinatal survivors is that they struggled to raise their children because they felt like they needed to protect them from harm. They think that especially their daughters will also be sexually abused. So they kind of act as a helicopter parent. And it can also be from the changes in routine and your changes in body. So for a survivor, it's difficult to have trust in yourself. So the hormone changes and sleepless nights, heightened sensitivity, and possible disharmony in relationships can bring up feelings of shame and guilt. So the third topic we're going to be talking about is what is trauma-informed care? So trauma-informed care is one of the critical methods for improving the mental health outcomes and adverse experiences of childbearing sexual violence survivors. So we want to shift that paradigm from what's wrong with you to what has happened to you and how can I help? So in a study that I looked at for the experiences of survivors of sexual abuse in childhood, the participants found that their healthcare professionals did not understand how sexual trauma adversely affected their perinatal experience. Therefore, it's important that healthcare professionals recognize the signs and symptoms of trauma in their patients or clients. So, kind of the goals and ideas of trauma informed care is that it takes into account the patient's life and situation to deliver effective care. It can improve patient engagement and commitment to treatment and care. So, like I said before, they prolong or avoid the attendance of exams. So, we want to get them committed to receiving that care so they don't experience any prenatal complications. It can also improve the mental health and well being, and it is applied at all levels of organization. So even the office administrator is trauma informed. So I took the ideas from the Substance Abuse and Mental Health Administration, and they outlined 4 key assumptions known as the 4 Rs, which is realize, recognize, respond, and resist re-traumatization. So a program, organization, or system that is trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery. They recognize the signs and symptoms of trauma in clients, families, staff, and others involved within the system. And they respond by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So, in a perinatal and maternal health context, this is to realize the nature of trauma and its impacts on pregnancy, and to recognize the signs and symptoms of trauma during and after pregnancy, and to respond by fully integrating knowledge, evidence, and sensitivity into all training and practice, and to resist re traumatization is universal in all care. So there are 6 principles of trauma-informed care. The first being safety, and this is where the organization and staff promote a physically and psychologically safe environment for their clientele. So this is from the physical setting to the interpersonal interactions. The second is trustworthiness and transparency, and this is where the organizational operations and decisions are conducted with transparency to build and maintain trust. The third is peer support, and this is where individuals with shared experiences are integrated into the organization and viewed as integral to service delivery. The fourth is collaboration. This is where the staff and other personnel share decision-making power with their clients and recognizes that everyone has a role to play in trauma-informed care. The fifth is empowerment, voice, and choice. And this component is when the organization supports the decisions and choices of their clients to promote resilience and self-advocacy. And the sixth is cultural, historical, and gender issues. And this is where the organization actively moves past biases and stereotypes and incorporates policies and processes responsive to gender services, racial and cultural needs, and recognizes historical trauma. So this is the last part of the presentation. So this is improving the perinatal mental health in practice. So it's important to remember that it's not the procedures and practices that are problematic. It's the way that they're conducted that can be problematic. So we want to promote a sense of safety. We want to give them control and autonomy and build a positive rapport between the client and provider. So I'm going to be covering universal precautions, meaning that they can be applied to all patient interactions, but trauma looks different in everyone. So understanding the client and their needs is important for specific care. So the first one is screening. So disclosure can be challenging. So screening is an effective tool that will help recognize what unique concerns will have to be monitored during pregnancy. So early screening is important in establishing risk assessment and mitigating complications throughout the survivor's perinatal experience. However, routine screening is just as important because many individuals don't disclose their first time due to shame, guilt, and fear. So it's recommended that they screen once every trimester and once in the postpartum period. Because survivors don't like to disclose many different times to different providers, it's important to consider keeping their screening information in an electronic health file. This way, other providers could access the screening information and they're able to deliver the care that they think is needed for them without having to ask about their past. However, this could violate confidentiality policies, so it's important to find strategies to help relay this information safely. And it's also important to screen the patient alone. So no family members present and no partners present. And screening in this way can increase the survivor's sense of safety, which is that first principle of trauma-informed care. There are also some barriers to screening, such as a lack of knowledge about trauma, screening tools, and further resources. It could also be because the provider is uncomfortable with the topic of sexual violence, or it could be due to a limited appointment time. So it's important that the provider be knowledgeable and confident to provide these screenings and know how to react to a disclosure. So being attentive and actively listening and being honest about what they will do with that disclosure information will promote that trauma-informed care principle of trustworthiness and transparency. So there's not one tool used, but there's three that I looked at that I found to, or that other studies found to be successful. So the first is the abuse assessment screen. This is 5 items that assesses the frequency and perpetrator of physical, sexual, and emotional abuse. And there's also a body map to document the area of injury. The third is the woman abuse screening tool. So this is 7 items that assesses physical and emotional intimate partner violence. And the third is the childhood traumatic event scale. And this is 25 items split into 5 subscales. So this measures emotional, physical, and sexual abuse, and physical and emotional neglect. So the second recommendation is a birth plan. Because control is a significant concern for survivors, setting a plan can tailor to their needs and restore power and autonomy. A plan can identify the client's priorities and triggers to avoid re-traumatization, as well as the selection of a birth location, the sex or gender of their provider, deciding who is present for the labor, and preferences for interventions such as determining whether they want cervical examinations and epidural or planning to breastfeed or not. And that collaboration with the healthcare provider can also meet that trauma-informed care principle of collaboration. So the birth plan can ultimately help build bridges with the provider and get to know the patient better and release any pressures of having to ask for something. So the third is consent. And it's important to remember that the patient has the right to decline any tests or interventions. However, if a test or intervention is needed, it's important that the provider always walk through the steps of what they're doing. So being transparent and give the individual a red light and green light. And this makes it clear that the patient is in control, that their choice will be respected, and eliminate any fears that they'll be viewed as a bad patient. So this kind of goes in hand with what shared decision making is. So shared decision making considers the patient's birth plan, their concerns, and their tests and diagnoses such as mental health disorders or past sexual abuse. And it also takes the input from the provider based on their knowledge, training, and education. And this creates an open discussion between the provider and patient. And this meets the trauma-informed principle of collaboration as well. And it's important with shared decision-making that the provider give them the time to be patient and make the choice that they think is best for them. So creating a safe space and not pressuring them to do something that they think they should be doing. So with the shared decision making, it's important to know the tend and befriend response. So I learned this from Angie Evans. She's a doula that I spoke to, and she's also a doula trainer for Birthways International. So kind of in short, the tend and befriend response is a stress response, kind of like fight or flight, but with tend and befriend, it's wanting to keep the peace in stressful situations. And this happens a lot during labor. So it can be difficult for someone to speak up for what they want and make decisions that they think is best for them because they don't want to create any more disturbances they think is already there. So it's just important to keep that in mind and practice shared decision making and allow them for that time to make the decisions they think is best for them. So some further considerations is to keep trauma-informed referrals ready. So this can meet the third TIC principle of peer support. It's also important to observe your own identity as the provider as well as the patient's. And this is because studies have shown that healthcare providers rate the pain of their patients of color lower than their white patients. And also, history has shown that many people of color don't trust the medical system due to the legacy of discrimination. So it's important to be educated on the impacts of minorities in healthcare and how providers give that care. And that also meets the sixth principle of trauma-informed care, which is cultural, historical, and gender issues. It's also important to pay attention to the language you're using. So using more formal language and adult terms can ease the anxiety of the survivors in the clinical setting. So saying to lay on the examination table instead of laying on the bed, or using terms like undergarments or underwear instead of panties. And it's also important to recognize and pick up on nonverbal cues of distress, such as muscle tension, flinching, tearing up, or stuttering, and stop and ask the patient how they're doing, if they need to stop, or how you can decrease the difficulty they're experiencing. And lastly, it's important to treat everyone as if they are a survivor. So, because these considerations are pretty straightforward, it's important to normalize them moving forward, and to give every birthing person a sense of empowerment in their perinatal journey. So, some of the biggest takeaways from this presentation is how the survivor is treated is more important than what happens. So even if the birth plan goes south, being patient and honest and empathetic is key. Also, to ensure the survivor is an active participant in healthcare decisions. Describe the nature and process for interventions, and give your options and empower survivors to make the choices they want. So not being coercive, and sorry, kind of saying what they think is best for them to do, because being in control is their main goal. So we want to give them more control. And to consistently ask for approval before moving forward and ensure that they can always say no. And we've reached the end. So, any questions? I'll refer to the chat. Okay. One thing that hadn't even occurred to me was gentle language nurses and doctors use during labor and how this can be triggering, like sweetie, honey, relax. What are some ways that the medical team can bring informed consent, more empowering language into the delivery room? That's a good question. I guess like just recognizing what their triggers are, and especially if they experienced that in childhood. So using kind of terms that you would call a child. So I would say just using their name would be a good way. How do we get this information to people who work with people in the childbearing year? Oh, that is also a good question. That I guess it's kind of difficult because it has to be put into policies and it's done on an organizational level. So making sure that the organization implements these kind of policies for people who work with childbearing people. I think if that answers your question. In speaking to survivors who have given birth and gone through this, what did they find healing? It's likely medical systems will continue perpetrating harm until this important work is integrated into policy. So how can we help survivors who have had traumatic birth experiences already? That is, I guess, because peer support, I think, is really helpful. So I don't know, maybe like a group of Mothers is a good one. I spoke to someone at the Perinatal Health Network who had a support group for new moms. So I feel like that would be a good option, kind of just to remember that you're not alone in all of this in your healing experience or healing journey, sorry. Thank you. Um, I will stop recording.